So we are live in 5, 4, 3, 2, 1. We are live now. You can start.
Yeah. Good evening, everyone.
I'll share my screen.
Sir, please. So, on behalf of Rajasthan Orthopaedic Surgeons Association and Jaipur Hand Surgery Society, I welcome you all for another series of master classes in hand surgery. Today's topic is on the fingertip injuries, which is a very common day-to-day issues in our practice. And we have a galaxy of faculty, the national faculty, Dr. Nikhil, Pande, and other Rosa faculties for today's webinar. To start the formal proceedings, I would like to invite Dr. Vinay Goyal, the president of the Rosa, for the formal initiation of today's proceedings. Dr. Vinay Goyal, sir, please. Dr. Nikhil, will you stop sharing your screen, please?
Hello, everybody. Am I audible?
Yes.
So, another series is there. And Dr. Amit Vyas is doing very hard work. And every month he brings new topic in hand surgery. And I am very excited. Only on fingertip. And there is a webinar is being done only on fingertip. So, let us see what expert says. And please start the proceedings. Yes.
Thank you, Dr. Goyal, sir. Now I will hand over to today's moderator, Dr. Amit Vyas, who is the Joint Secretary of the Rosa, for further proceedings of today's webinar. Over to you, Amit.
Thank you, sir. I'm highly thankful to Rosa official, especially Dr. Vinay Goyal, sir, Dr. Rahul Katta, sir, to giving me this opportunity to organize this webinar. Fingertip injury are most commonly encountered injuries in our orthopedic practice. And you will be, if you know that only two parts of another human being we can see, one is the face and second one is the hand. So if fingertip injuries are not managed properly, it gives a very bad cosmetic appearance. And second thing, fingertips are quite sensitive. You can understand this fact by knowing that the deaf and dumb person can read with the help of the fingertips. So these are quite sensitive things. So we need to restore the sensation. So so we organize this webinar to make us more educated about managing the fingertips and to know what is the importance of fingertip and how we can cover the other defects of the hand also. For this, we have invited Dr. Nikhil Pande, sir. And Dr. Nikhil Pande is a dear friend and he's quite helping in our Indian Society of Surgery of Hand meetings. And he's associate professor at the BZ Government Medical College. And he looks like quite a cute boy, but he has huge academic career. And he's associated editor of Indian Journal of Plastic Surgery Journal. And he has awarded with the Best Teacher Award in 2019 at BZ Medical College, and various awards like Cleaner Essay Award in 2015 and 2013 FC, and Best Paper Award in ISSS meeting in 2010 and 2015. He has 60 publications in peer review journals and various book chapters, and he has 412 citations, and he has patented one technique, epidermal suspension spray device, and he's reviewer of various journals in hand surgery and plastic surgery journals, and he's quite active in education. In the modern era, he's teaching the fellow all over India and abroad also by his YouTube channel. And you will be surprised that he has 8 lakhs views and nearly 8,000 subscribers over his YouTube channel. And with this, we have our another Rosa faculty, Dr. Aviral Gupta. He's consultant hand surgeon at Khandaka Hospital, Jaipur. And Dr. Thawar Maida, he's consultant orthopedic surgeon at Banswara hospital that is going to be converted into Banswara Medical College soon. And we have Dr. Madhu. He's our budding hand surgeon from the Jaipur. And we have our president, Dr. Vinay Goyal sir, and Rosa secretary, Dr. Rahul Katta sir. So with this, I would like to invite Dr. Nikhil sir for to deliver his talk.
Thank you, Amit, for the extremely gracious and kind words. And thank you all Rosa members and respected chairpersons for having me to deliver this presentation on hand flaps. So I'll be basically trying to cover non-microsurgical options for coverage of hand defects and finger defects. So we'll cover dorsum of hand, volar aspect of hand. Then coming to fingertips, we will cover volar aspect of fingers, dorsal aspect of fingers, and in addition, fingertips and as well as thumb defects. So I'll basically take you through the entire spectrum of the flaps which we do for these defects, and take you through the principles of management of how to choose and how to go ahead by with selecting these particular flaps for these particular defects. So first of all, just a quick word about why to go ahead with non-microsurgical reconstruction, because in this era of microsurgery, various people are reluctant to go for non-microsurgical options. But yes, there can be various reasons. There can be paucity of recipient vessels. Microsurgical skills might be lacking. We might not be confident in our microsurgical training. There might be infrastructural inadequacies. Cost is also very prohibitive when microsurgery is concerned. And then, of course, there is, after failure of free flaps, we tend to look towards the loco-regional options. And in addition, non-microsurgical flaps also have their own set of advantages, wherein they can be considered as the first choice of reconstruction, especially for hand and finger defects. So in non-microsurgical options, we have loco-regional options and distant options. Distant options are commonly performed. Groin, abdomen, and chest flaps are the donor sites for distant options. For loco-regional flaps, we commonly have the reverse radial flap, which can cover almost the entire hand. Then we have perforator propeller flaps, which are upcoming, which are quite easy, but yet are not very popular. I'll take you through some of the videos and clinical scenarios of when these flaps can be performed. So these are the radial artery perforator flaps, ulnar artery perforator flaps, anterior interosseous artery perforator flaps, PI flap, facial flap, and other options. Now coming to decision making as to when we should go for distant options and when we should go for loco-regional options. So distant options like groin and again, there are stages involved, especially in chronic or neglected hand injuries. If we go for a groin flap or an abdominal flap, it further gives rise to dependent edema. Physiotherapy is delayed and there can be more stiffness of the hand because of all these factors. Then there is this advantage of a hidden scar, which is not there in loco-regional flaps. So loco-regional flaps, we are able to cover defects, but these are comparatively smaller in dimensions as compared to those of distant pedicle flaps. The most important advantage is that it is a single stage flap. The patients get to work very fast. And the major disadvantage over here is there is poor donor site aesthetics. When we do a radial artery forearm flap or any flap from the forearm, there is graft over the donor site, and obviously it doesn't look good. So these are the various points which we have to consider when we take a decision regarding which flap is an ideal flap for a particular patient. So obviously we have to discuss these options with the patient and then come to a conclusion as to which flap do we want to perform for this particular patient. Now coming to which pedicle distant flap should we perform? Should we go ahead with the groin flap, abdominal flap, or a chest flap, thoracoabdominal flap? So the most important points to be considered are the position of comfort. Since the patient has to keep this hand in that particular position for a period of around 3 weeks, position of comfort is a must. If the patient is not comfortable with a particular position, the flap is not going to work at all. We have to see that the position is in such a way that there is maximum inset of the flap over the raw areas. So these are the two most important points. Then we have to use the thinnest possible flap. Now groin and chest skin are thinner, so those are better options if position of comfort and area of inset are maximum. If we have to go for abdominal flap, and both the flaps are an option, that is, we can do a superiorly based abdominal flap as well as inferiorly based abdominal flap. It is important to note that more of fat is there in the inferior abdominal region. That is why superiorly based abdominal flaps are thicker as compared to inferiorly based abdominal flaps. So whenever possible, when both are an option, inferiorly based abdominal flap should be preferred to superiorly based abdominal flap because those are thin flaps. Now, this is an example of a groin flap wherein we have given almost 70 to 75% inset. It is a thin flap. Post-operatively, it looks very good. Donor site is hidden. Lateral thoracic flap, one of the advantages of this flap when we compare all the distant flaps is there is no dependent edema. Since the patient's hand is elevated up to the chest level, the dependent edema is minimized to a significant extent, and it can be a very good option when it is possible to give this position to the patient. Now, this is an inferiorly based abdominal flap. If you appreciate the thickness of the skin, you can see that it is quite thin as compared to superiorly based flap. Now, also, there are various advantages of inferiorly based abdominal flap. There are known source vessel in it. There is SEPA, there is SIEA, there is SCIA. So these vessels are named vessels which form the basis of various abdominal flaps which are inferiorly based. For superiorly based flaps, these are random pattern flaps, and this is how it looks. A superiorly based abdominal flap is comparatively thicker as compared to inferiorly based abdominal flaps. So we might need to thin them at a later date. Abdominal flaps need thinning for sure. Some of the surgeons go for primary thinning, some of them go for secondary thinning. So aggressive primary thinning might be a bit problematic in some of the cases. So I personally prefer to go ahead with judicious secondary thinning. So this is how we take a call regarding which flap to do. And then there are some cases wherein the defect size is very large, and we can do a combination of both a superiorly based abdominal flap and an inferiorly based abdominal flap. So that way we are able to cover significantly large area of significantly large defect with appropriate positioning. Now coming to some of the points which we can use to optimize the outcomes of pedicle distant flaps. So we can narrow the base to permit mobility and maximize the inset. So especially when it comes to lower abdomen, the SCIA, SEPA and the SIA flaps, we can narrow down the base to include a known source vessel. So that way we get more amount of mobility and the patient is comfortable moving the hand. Then there should be judicious primary thinning, or if at all, secondary thinning should be considered. whenever we are dealing with defects which involve the hand, palm, as well as the thumb, it is better to do 2 flaps when thumb is involved, because the axis of the thumb is different. And when we need to put in a bone graft, it is better that 2 different flaps are used for the palm as well as the thumb. Coming to loco-regional options, for the dorsum hand, our flap of choice is the anterior interosseous artery perforator flap. For dorsum of hand extending beyond the metacarpophalangeal joints, reverse radial flap is the flap of choice. Proximal palmar region, we have perforator flaps because the extent of the perforator flaps in the distal palm and beyond the MCP becomes a bit dicey. So we have radial artery perforator flaps, ulnar artery perforator flaps, anterior interosseous artery perforator flaps. For the distal palmar region, we have the reverse radial artery flaps. And if it is a small defect, we can also go ahead with the radial artery facial flaps. Entire palm, our flap of choice is reverse radial artery flap or the ulnar artery perforator flaps. Now I'll take you to the clinical spectrum of these cases as to how it is done. So for dorsum of hand, large defects, reverse radial artery flap is the flap of choice. Obviously, donor site aesthetics take a beating over here. But these flaps can comfortably cover the entire dorsum of the hand. We have to do a pre-op Allen's test. We have to see that the patency of the ulnar artery is intact because we are going to sacrifice the radial artery. And then taking a pivot point at around 2 centimeters proximal to the wrist, we plan in reverse, and a reverse radial artery flap is done for dorsum of hand defects. Similarly, the reverse radial artery flap can cover regions, metacarpal head regions of all the fingers, index fingers, the first web space, and also can cover defects of the proximal phalanx. Now, there are certain defects in the palm, which can be in the proximal palm or in the distal palm, wherein we need to plan a facial flap. Because what happens is when we use a radial artery forearm flap for coverage of palm, the flap becomes too thick, it is insensate, there is problem in cupping of the hand and in complete flexion of the hand. So in these cases, radial artery forearm flap, I mean the typical radial artery forearm flap with skin component might not be a good option. In those cases, radial artery only facial flaps can be used. These can be tunneled not from the volar aspect of the palm, but from the dorsal aspect of the palm, so that the palm is having minimum number of suture lines. There is no chance that the scar might be painful or tender at a later date. So radial artery facial flaps can be used for isolated palmar defects, which are reasonably smaller in size, and especially in the distal palm. We have got cases wherein the arch is not intact, there are palmar injuries. So in this case, obviously radial artery forearm flap is not an option. The radial artery is damaged, either or the ulnar artery is damaged or the palmar arch is damaged. So in those cases, we can go ahead and do a radial artery perforator based propeller flap. So here in the second image, you can see that the radial artery is intact. The flap is islanded on the perforator of the radial artery and is axially rotated through 180 degrees to cover the defect of the palm. So radial artery perforator based propeller flaps are good flaps for these type of defects. Then there are certain defects which are composite in nature. Now here you can see that there is a defect with loss of EPL as well. So in this case, we have done a tendocutaneous radial artery perforator flap. So we have harvested the palmaris longus along with the radial artery perforator flap. So it is a composite flap. It has got skin, fascia, as well as the palmaris longus. So the palmaris longus is used to bridge the segmental gap in the tendons at the same sitting, and it is also providing soft tissue coverage. So in these cases like these, we can do a single stage reconstruction of tendon as well as soft tissues. So this is also done in a propeller manner. In this case, the advantage is that we are using a tendon flap. The tendon is vascularized. It is not a tendon graft. It is not a free graft. and so the healing is better as compared to free tendon grafts. Similarly, as we have done a tendocutaneous flap, we can do a neurocutaneous flap. Now, this is a defect with exposed ulna, wherein we have done ulnar artery perforator-based propeller flap. Again, in this case, we have used cutaneous nerve in this flap, and we have bridged the segment of the ulnar nerve. So, one segment which is used in the flap is vascularized nerve flap. It is, the outcomes are much better as compared to free nerve grafts when the nerve graft is vascularized. So, neurocutaneous perforator flaps, which can be axially rotated through 180 degrees, are also a good option for coverage of hand and wrist defects. Now, again, coming to the palm. So, in this case, we can see that almost the entire palm is involved, and radial artery, it is, when the palm is involved, the arch might be damaged. So, it is a bit riskier to use reverse radial artery or reverse ulnar artery flaps. So, in this case, ulnar artery perforator-based propeller flap was used. You can see the intact ulnar artery in the central image. The flap is harvested, and distal ulnar perforator is a significantly large perforator. So, on that, the flap is axially rotated through 180 degrees to cover the entire palm. So, ulnar artery perforators are significantly large in dimensions and can comfortably be used to cover the entire palm with a single flap based on a single perforator. Posterior introitious artery flap is a very tricky flap. I personally dislike this flap very much because of the complications, the venous problems arising with these flaps are significantly large, and we don't prefer the posterior introitious artery flap. We do the anterior introitious artery perforator flap. The dissection is much easier. It is based on the perforator of the anterior introitious artery, which is coming proximal to the wrist joint at a level of around 3 to 4 centimeters. Now, here you can see that there is a defect on the dorsum of the hand, as well as the defect is there on the volar aspect of the hand. The flap is harvested in such a way that we are using the proximal part of the flap to cover the dorsal defect, and distal part of the flap after the deepithelialized segment to cover the volar aspect of the defect. Now, you can see that there is partial necrosis of the distal half, the small tail which is there, but eventually, yes, the fascia survived, and you can see the post-op outcomes with the fingers in full extension, showing that there was no deficit in range of extension by the use of this flap. So, anterior introitious artery perforator flap is a very good flap. We don't have to go till the posterior introitious artery. We don't have to dissect in the septum. We don't have to go deep. It is based on the anterior introitious artery. We just have to take care to preserve the perforator and the plexus near the wrist joint and go ahead and do this flap. For web space defect, we have the reverse dorsal metacarpal artery perforator flaps, which can be axially rotated again to cover the web space defects. And we have the superficial palmar branch of the radial artery flap, which is used for mid-palmar defects. So it is a smaller flap. In this case, we have not islanded it on the superficial palmar branch of the radial artery. But yes, if we have to increase the reach and arc, we can also island it. So these were some of the cases for hand defects. So to conclude for hand defects, regarding decision making, patients who present late, who are having difficulty in repeated visits, who are non-compliant to physiotherapy, especially who are daily wages workers, sole breadwinners, who have to get back to their work as early as possible, should be considered for loco-regional flaps. We don't want to give them stages, first do a flap, then detach it at 3 weeks, then further debulkate. So we don't want to do that. And so in these type of patients, loco-regional flap, loco-regional flaps are our first choice. Patients who have concern for donor site aesthetics and the defects are quite distal for local flaps, in those cases, distant pedicle flaps are our flap of choice. So in that cases, we can use groin, abdomen, and all these type of flaps. Now coming to the main topic which Amit wanted me to focus on, is finger defects. So we will discuss about various flap options for volar finger defects, dorsal finger defects, fingertip defects, a combination of defects, volar and dorsal defects, and thumb defects as well. I'll take you through the entire spectrum of these flaps. Now, there are a wide variety of flaps which have been described. Various authors have described various flaps for management of finger defects and fingertip defects. Multiple modifications have been described for these flaps, but yet, as we all know, there is no ideal flap when it comes to managing a finger defect. So we have to follow some general principles, and on a case-to-case basis, we have to decide what is the best option for that particular patient and what is the flap of choice for that particular surgeon. So the general principles which we should consider are: our flap should be thinnest possible flap. Preferably, we should use injured digit first before going to the uninvolved and the non-injured digits. Preferably, our reconstruction should be a single stage reconstruction. Whenever large areas of defects are involved, we should use flaps only for critical defects wherein tendon or neurovascular structures are exposed. For all other flaps, we can use a skin graft. And obviously, especially when we are dealing with fingertips, we should prefer sensate flaps. So these are the general principles which we should consider while thinking of a flap for managing a finger defect. Now I'll take you through the spectrum of the various flap options. Coming to volar defects first. So this is a defect on the volar aspect of the index finger. And as you can see, this is a very edematous finger. It is a neglected hand. And as we just discussed, it is not a wise idea to do a pedicled groin or an abdominal flap for this large defect. So in this case, we have done the conventional cross finger flap. So this is a classical full finger cross finger flap. Generally, we do smaller cross finger flaps, but yes, we can do cross fingers for the entire length of the finger, crossing the PIP joints. It is very important to take care that the paratendon is not damaged because we are going to graft this area. Of particular importance is to note that it is very likely that the paratendon gets exposed near the DIP joint. So that is the area where we have to be more careful. And the fourth image is showing well inset of the flap. And you can also see that the edema is significantly reduced. Now, this is excellent post-op outcome at around, I would say, 3 to 4 months of follow-up. The edema is completely gone. And you can see that the middle finger is looking, the aesthetic outcomes of the middle finger are really good. There is complete flexion and extension of the middle finger. So full finger, cross finger flaps can be used to comfortably cover the entire volar aspect of fingers. And in spite of using a full finger flap, we have got very good aesthetic outcomes. Now, especially when we come to volar defects of the little finger, we have the ulnar digital artery perforator flaps. In the on the right side of the image, you can see that the tendons are exposed, and we have used the ulnar digital artery perforator flap. It is axially rotated through 180 degrees to cover the defect, and the donor site is grafted. So for patients where we don't want to involve the adjoining finger, uninjured finger, we want to do it in a single stage manner, these are the flaps of choice. These are a few cadaveric dissections which we had done initially, wherein you can see that the ulnar nerve is intact and the perforator is entering the flap, which has to be identified and safeguarded. Now, again, there are volar defects for which we can do mid-palmar flaps. Now, this is a cadaver studies, and generally in a clinical scenario, we avoid mid-palmar flaps, but this is just to show you the spectrum of the flaps which can be done. So the first image is showing the flap marking overlying the common palmar vessels. The second image is showing the digital nerves which are identified and safeguarded. The third image is showing the bifurcation of the common digital vessels which are below the digital nerves. And then we have to sacrifice one of those common digital arteries so that the flap can be harvested and then it can be made to reach the defect. So mid-palmar flaps can be used. Important disadvantage of these flaps are we have to sacrifice one of the palmar arteries. And again, these flaps tend to give a scar over the palmar aspect of the hand. So these are to be avoided. Then this is an interesting flap which not many people do, but it is very easy to perform. It is very safe. This is the transverse perforator plus flap. Now this is a patient wherein we can see that the little ring finger has been amputated traumatically, and we have the donor site in this particular case is the area which is distal to the distal palmar crease. So that area you can see is quite lax. It has got a lot of oblique perforators coming out of the common digital vessels. And in this case, as you can see that we have harvested the flap and transposed it through almost 90 degrees. The flap is not islanded. It is a very safe flap. It has got known perforators in its base. We need not identify and isolate the perforators. We just have to plan in reverse. And in the last image, you can see that we have a very well settled flap. The flap is comfortably covering the volar aspect of the ring finger. So these type of flaps are used for smaller defects. We won't be able to use this flap for covering the entire volar aspect of the middle finger or the ring finger. But for smaller defects wherein the proximal phalanx is exposed or involved, this flap can be very nicely used with good aesthetic as well as functional outcomes. Then there is this volar, for volar defects, there is this palmar flap. It is an inverted U-shaped flaps, which is typically used for burn contractures. So in this case, what we do is we harvest this flap, we take an inverted U-shaped incision, and through that incision, we release the contracture so that we have a straight finger. The vascular basis of this flap is from the reverse flow, which is coming through the digital vessels. Now, it is important to note that this is not an advancement type of flap. It is a pulling type of flap. So the flap is not advanced into the defect. It is pulled into the defect. Technically, very, very easy flap to perform. It is based on slightly the subdermal plexuses as well as subcutaneous plexuses. It is important that we don't harvest a very thick flap and neither a very thin flap. The flap should be intermediate thickness and it covers the defect in an excellent manner. As you can see in the post-op image, there is slight terminal necrosis, but this was an early post-op period, and in around 3 to 4 months time, this will settle beautifully. Now coming to dorsal defects of fingers. So this is a classical dorsal defect which we encounter very frequently. So for dorsal defects, Quaba is our flap of choice. So as described by Quaba, it is based on the intermetacarpal perforators. So we Doppler the perforator with a handheld Doppler. Then we measure the distance from that perforator to the distal edge of the defect, plan in reverse, and then again this flap is axially rotated through 180 degrees to cover the defect over the dorsal aspect of the finger. Very safe flap, very reliable flap, but if the defect is going beyond the proximal phalanx, this flap becomes highly unreliable. I personally don't suggest that we use this flap when defects are extending beyond the proximal phalanx. Proximal to the proximal phalanx, it is an excellent flap. Beyond the proximal phalanx, it becomes a very risky flap. Again, one of the important points of this flap is our flap shouldn't go on the or shouldn't extend on the wrist. So that is why we have turned this flap. We have given an angle to this flap so that it doesn't encroach on the wrist and it is in the safe territory wherein it can be harvested comfortably. Again, there are certain defects wherein we can't do a Quaba. Like this is a neglected hand. There is a lot of scarring. It is a old hand. We are not sure of the perforators. Perforator signals are not good. So in this case, we can do a cross finger flap. This is not our conventionally based cross finger flap. This is a proximally based cross finger flap from the adjoining finger. But again, it is a very good flap. It is a very easy flap to execute and a very robust flap. Again, while harvesting this cross finger flap, due care must be taken so that we don't expose the paratendon, like our conventional cross finger flap. And you can see that the flap is well settled. Graft take is also very good on the donor side. Then there are smaller defects over the proximal phalanx or beyond that, where we can do our conventional transposition flap. So conventional transposition flap is based again on the lateral sided perforators of the digital arteries. And for smaller defects, as you can see, donor side can be comfortably closed in a linear fashion. If the defects are large, in that case, we might need to graft the donor area. For defects like these, we can also do simple adipofacial flaps. Simple adipofacial flaps can be used and grafted. So defects like these are typically difficult, especially when we don't want to do a cross finger flap. A cross finger flap in a reverse cross finger flaps can be done for these type of defects. But if we want to go for homodigital options from the same injured digit, we have to go for transposition flaps, which are very large flaps. Then it gives a dog ear like this, which can be tackled at a later date if the patient is concerned. As you can see in the second image, the donor area is grafted with an intermediate thickness skin graft and is looking really nice. So for dorsal defects, transposition flaps are a good, fast, safe option for coverage of small as well as large defects. Now coming to fingertip and pulp defects. Now for fingertip and pulp defects, neither the surgeons are in consensus. There is a battle between surgeons as well regarding which is the flap of choice, and there is a tussle between the flaps as well, as all flaps have their own set of advantages and disadvantages. So there is again no ideal flap for fingertip and pulp defects. We have the time-tested and the robust cross-finger flap. It is not a sensate flap, but it can be done, harvested in a sensate manner. Even if it is not harvested in a sensate manner, cross-finger flaps do regain protective sensation in around 6 to 9 months of time. Flap harvest technique is the same. We plan in reverse. We take care that we don't damage the paratendon, and these outcomes are very good. The learning curve is very less. So that is why cross-finger flap is very popular amongst all of those who manage hand and finger injuries. Then there is this thinner flap. Now, classically, it is done in a distally based manner, but in this case, we have done it in a proximally based manner. It all depends on the proper positioning. One of the important advantages of thinner flap over the cross finger flap is there are a lot of sensory nerve endings in the donor area of the thinner flaps. So long-term outcomes, the sensory recovery of thinner flap, the sensory it is much better. The sensory recovery of thinner flaps is much better than cross finger flaps in long-term follow-up. Again, these flaps are also two-stage flaps, same as the cross finger flap. So that is one of the disadvantages. If adequate and aggressive physiotherapy is not started early on, it might lead to stiffness of the PIP joint. So these factors must be considered when we are considering a thinner flap or the cross finger flap for management of fingertip defects and pulp defects. The flap of choice of most surgeons and myself personally is the Venkataswamy VY advancement flap. It is the islanded neurovascular flap, which is used for fingertip defects and management of pulp defects. The major advantage is it is a single stage flap. Like is replaced by like. You can comfortably advance this flap for almost 1 to 1.5 centimeters easily. If you go in the palm, you can advance it even further. It is a sensate flap. So I think it comes near the criteria of being an ideal flap for management of fingertip and pulp defects. The only disadvantage which I think is that it gives scarring over the volar aspect of the finger. It might lead to a painful scar at a later date. So how do we plan a Venkataswamy flap or a VY flap for a pulp defect? Generally, the dominant pedicle is preferred, and it also depends upon the obliquity of the defect. So we have to plan the flap in such a way that the obliquity is on the maximum side of the defect. so that it comfortably covers the defect. So these are the three flaps which are used commonly for fingertip and pulp defects. Then there is the reverse homodigital flap. The reverse homodigital flap is an interesting option for managing fingertip and pulp defects. The disadvantage of this flap is we have to sacrifice one of the digital vessels. So we have to do a pre-op Allen's or at least intra-op Allen's to see that both the digital arteries are intact and supplying well. It is based on the perforators and the communication between the two digital arteries at the level just somewhere in the middle phalanx, just proximal to the DIP joint. So that area must not be violated. We have to go comfortably till that area and then cover the flap, propel the flap, rotate the flap to cover the defect. One of the other disadvantages of this flap for fingertip defects is that we are likely to damage the digital nerve because the nerve and the artery are going close by. So dissection is a bit tedious. It takes a lot of time. If the donor site is closed primarily, as is done in this particular case, there is flexion of the IP joint. So it doesn't go easily. We have to do aggressive physiotherapy. So if we are having larger defects, it is better that we graft the donor site. So when we graft the donor site, there is no problem with the flexion of the IP joint at the donor finger, and flap can comfortably cover the fingertip defects. Now coming to thumb defects. Now thumb defects going from proximal to distal, we have the classical FDMA flap, the first dorsal metacarpal artery flap, very time tested, robust, known axial vessel, known axis of the vessel. So we plan in reverse. It is very important to incise the fascia over the first dorsal interossei while harvesting this flap. After that, this flap is a very reliable flap and it settles very well. It is thin flap. For thumb tip defects, we have the reverse dermal cross finger flap. So there is always debate between what can be the donor finger for a cross finger flap when we are doing it for the thumb. Index finger is generally not preferred because of its aesthetics and it being the second most important finger after the thumb. Middle finger and ring finger can be comfortably used depending upon the positional comfort of the patient, depending upon the defect. So in this case, we have used the reverse dermal cross finger flap for a thumb dip defect, and this reverse dermal cross finger is then grafted. So decent aesthetic outcomes for the thumb. Again, for thumb tip, also we can do the first dorsal metacarpal artery flap. The FDMA flap can comfortably reach up to the thumb. You can see that the flap is islanded on the vascular pedicle. It is then tunneled, and as you can see in the last image, the FDMA flap can be comfortably used to cover the thumb tip defects as well. Then there are certain circumferential thumb defects. These are very rare defects, but yes, occasionally we do get these type of defects, especially in cases of electrical burns. So we have a defect on the dorsal aspect, volar aspect, and the thumb tip and pulp are well preserved. The integrity is well preserved. So in this case, we can do a bilobed FDMA flap. So we take skin from the territory of the first dorsal proximal phalanx of the index finger as well as proximal phalanx of the middle finger. Again, this flap is islanded and it can be circumferentially used to cover the circumferential defects of the thumb. Here you can see post-op well-settled flap wherein the flap is used to cover circumferential defects of the thumb. So FDMA is a very versatile flap. A very ideal flap for thumb defect. The only drawback is that the donor site aesthetics, donor site over the index finger has to be grafted. Then coming to other options for thumb tip defects, we have the Moschella flap or the radial thinner flap. Again, as you can see, this is based on the vascular basis of the radial thinner artery. So the vascular basis is from the radial artery to the thumb. We Doppler the radial thinner artery because it might be absent in some cases. The Doppler signals are very good. The pivot point is kept slightly around 0.5 centimeters proximal to the IP joint. So as can be seen in the second image, we are taking a tail along with the flap because it is helpful to cover the defect with the tail. It doesn't get compressed. So that is one of the major advantages. And you can see a very well settled flap. So radial thinner flap can be a good option for managing thumb tip defects. Donor site is also closed primarily. So donor site aesthetics is also not a concern. We don't need a graft. So for thumb tip defects, radial thinner flap can be a very good option. Similarly, we have the dorso-ulnar or the classical Brunelli flap. Again, it is a similar flap. It is a reverse flow flap. Principle remains the same. Only the known source vessel changes. Pivot point is again kept around 0.5 centimeters proximal to the IP joint. Flap is planned in reverse. In this case, one of the probable drawbacks of this flap is that we are likely to cause contracture of the first web space. And if there is contracture of the first web space, it might be detrimental. So we can use either a smaller Z or a transposition flap to cover the donor site. And we start aggressive physiotherapy early on so that there is no first web space contracture. So the dorso-ulnar flap or the Brunelli flap and the dorso-radial flap or the Mosella flap are good options in addition to the first dorsal metacarpal artery for managing thumb defects. Then we have combined volar and dorsal defects of digits. So defects like these are commonly encountered in ring avulsion. So in these cases, our classical flap of choice is the groin flap. We can do a primary thinning of the groin flap or do a secondary thinning of the groin flap. These gives good aesthetic outcomes and good range of movement if joint structure is preserved. Again, for similar defects, we can use the transverse perforator flap, which we discussed while managing finger injuries previously. So in these cases, again, the flap is raised. It is a bit longer in size so that the flap turns on itself and covers the volar defect as well as the dorsal defect. Very safe flap, very easy to execute, non-vascular pedicle in its base. We have got no need to identify the perforator, no need to see the perforator. It is always there. The disadvantage of this flap is it can be used only for terminal digits, either the index finger or the little finger. Because central fingers, we are not able to harvest these long flaps. So combined defects, we can use the transverse perforator plus flaps for volar as well as dorsal defects. Then again, there are certain defects like these. Ideally, we would prefer to do a groin flap, but in very rare instances, when the patient is not willing for a groin flap, we have a local option. So in this case, our conventional cross finger flap, the full finger, almost 3/4 of the finger to cover the volar aspect of the index finger. Then the dorsum of the proximal phalanx, as we discussed, we can do the quava flap. Now in this case, the quava is extending just beyond the proximal phalanx and it had some problems. There was terminal necrosis of this quava flap. And as you can see, there is slight shortening of the digit because we had to debride that particular flap. But even in spite of that, you can see excellent aesthetic outcomes of the cross finger flap as well as the quava flap. We had a very satisfied patient. So one of those cases wherein we had a satisfied patient but a dissatisfied surgeon with complication rate. So for combined defects, we can always use a cross finger flap with quava flap for management of such defects. Now coming to multiple defects of digits extending to the hand. So we have our classical groin. We can initially syndactylize the multiple digits and do a groin flap and divide the groin flap at a later date. Or for multiple digits with larger defects, we can go ahead and do a radial artery forearm flap. So in this case, as you can see in the second image, we have done a flap in flap. The radial artery forearm flap was divided and part of the flap was used to cover the thumb. Part of the flap was used to cover the volar aspect of the digits. And then again, after syndactyly separation, you can see the post-op outcomes in the fourth image. Now, for multiple digits with defects on the dorsum of the hand. Now, in the previous image, we saw multiple digits involved with defect on the palmar aspect of the hand. So for these defects also, we can do the reverse radial artery forearm flap. As you can see, the flap is comfortably covering the defect up to the fingertip, almost the fingertip on the dorsal aspect of the finger. Again, the digits are syndactylized and we have got full range of flexion. The patient was satisfied with the aesthetic outcomes and didn't want the syndactyly separation. So that is how we had to leave it. The disadvantage of this flap, as you can see, is the aesthetic outcomes. There is hair bearing area, a lot of hair bearing area over the fingers as well. And then there is graft over the forearm, which also doesn't look aesthetically good. So coming to conclusion for managing these finger and thumb tip defects, there is no ideal flap. There is a lot of variety, lot of spectrum of flap we have in our armamentarium. The patient's functional demands and our expertise determines the reconstructive strategy. So it is preferable to use the most straightforward option that addresses the reconstructive needs with minimal donor site morbidity. And it is very important to stress the importance of the comfort of the surgeon, because I think that is one of the important parameters while reconstructing these defects. There is no right or wrong. There are a lot of areas of gray, and comfort and expertise of the surgeon while executing that flap is of paramount importance rather than doing some unknown, unseen flap. It is better that we stick to our routine, and those flaps which are comfortable are always good in our own hands. So I think that was about my experience about managing hand and finger defects and fingertip defects. Over to you, Amit, if
Thank you, sir, for such elaborated talk. We have some questions. First of all, how you take care of stiffness, because it's a common problem. So, how you take care of it?
yes, there are certain things which should be considered, like the area of immobilization. The duration of immobilization is certain. For certain flaps, for cross finger flaps, or thinner flaps, at least 2 to 3 weeks of immobilization is mandatory. So we can't do anything about that. But since the beginning of doing the procedure, we counsel the patient that aggressive physiotherapy is going to be required, especially for the donor finger, or else we might land into problems. So aggressive physiotherapy must be stressed on. And what we do is we don't remove sutures till the patient regularly comes for follow-up. We keep on calling the patient for follow-up, because I work in a public sector hospital, in a government hospital. And what happens is, once we remove the sutures, flap is divided, sutures are removed, patient don't come back. And then they come back at around 3 to 4 months with extremely stiff fingers. So what we do is we don't remove the sutures at all. We keep on calling them, and when we are sure that they are doing good physiotherapy, then and then only we remove the sutures and sort of make them free. So I think the only key to avoid stiffness is aggressive physiotherapy.
Okay, sir, do you use composite graft?
Not commonly, especially in children. Distal fingertip injuries, yes, we do try composite grafts. But for adult patients, what we do is we remove that skin from the composite component which is there, and we use it as a full thickness graft. So that takes very well, especially in acute injuries. If the patient comes at a later date when it is all dried and shriveled up, then there is nothing we can do. But acute phase, we just sort of debulk the composite block and use it as a full thickness graft after radical thinning.
what is your preference for covering the palmar defects of the hand?
Palmar defects, if we are going to use a distant flap, it is always a groin, and a local flap, it is always a reverse radial flap. So that, as I just discussed, it depends on a lot of factors. If the injury is old, it is a neglected hand, edematous hand, we are sure that the patient is not going to do physiotherapy, then no groin flap at all. It is a reverse radial flap, single stage flap, limb elevation early on, early physiotherapy, early mobilization, and early back to work. If the patient is a bit well educated, living in the surrounding areas, likely to come for follow-up, knows the importance of physiotherapy, is educated enough to do physiotherapy, then go ahead with a groin flap. Otherwise, a reverse radial flap.
Any other faculty want to ask? Yes, go ahead, sir.
Yes, sir, please.
Dr. Panse, so
Sir.
why do you prefer groin flap over reverse radial flap?
So we don't prefer.
Yeah.
I personally prefer reverse radial flap almost always.
Yeah. Because groin flap is too much of the morbidity, I think.
Actually, sir, there is quite a lot of debate in this, especially with the team of Ganga Hospital. They, especially when you have patient with a reverse radial artery and a groin flap sitting together, the patient with the groin flap is happier because he doesn't have that scar over the forearm as compared to radial artery flap. So that doesn't look good. But I think that comes at a later date when everything is settled down. Initially, when we are doing it, we consider that the patient is coming from somewhere outside the state. He's a daily wages worker. If we are going to do a groin flap, where is he going to go? He will need readmission, repeated surgeries. So considering the clientage of the patient coming to us in a public sector hospital, we prefer a local flap. But yes, if in a private sector, if the patient is educated, if the patient doesn't want a scar over the forearm, then we can always go ahead with a groin flap. It is a very safe flap, very reliable flap. Donor side morbidity is very less. Donor side scar is covered. So yes, if I had to get it done for myself, I would prefer a groin flap.
Okay. Thank you.
Thank you, sir.
Any other question? Sir, you want to demonstrate your videos?
I have a couple of videos. If we have time, I can show them. It is up to you.
Just commonly used some.
I'll show anterior introduction. I'll show the quava. I'll stop sharing and again start sharing in a minute. Hi, this is a show. So this is a video of the anterior introducous artery perforator flap. I am showing it here because it is a very easy option, especially since most of the audience are orthopedicians and doesn't involve a lot of microsurgical work, and it can be used for a variety of options from dorsum hand to volar aspect of the hand. So it has inbuilt audio in it. Short video on the anterior introducous artery perforator flap, especially for hand defects, the defect which we have seen. We are marking the axis of the flap, which is from the distal radial joint to the lateral epicondyle, same as the posterior process artery. Amit, is the audio and video both seen?
Yes, sir. Audio is slightly. They are not able to hear clearly audio. Can you demonstrate?
Yes, yes. I'll how do I close the audio of this so that I can?
You can mute it, sir.
Yes, I am trying to. Short video on the short. Yes, we are talking that. Yes, I'll give the audio myself. So that is the defect which we commonly encounter in clinical practice. So we are marking the axis from the distal radio-ulnar joint to the lateral epicondyle. Around 4 centimeters proximal to the wrist joint is the perforator which is commonly there. So from that point, we measure distance to the distal extent of the defect. That point is replicated on the axis, that is planning in reverse. Then we take the template of the defect, what we have. That defect is marked on the axis. So we take into consideration thickness of the skin because we have to take a slightly larger flap as compared to the dimensions. And then we take a tail along with the flap. Now initial incision is taken on the ulnar border to identify the perforator, but it is absolutely not necessary to identify the perforator. The perforator is almost always there, but this is just for the sake of demonstration. So here we can see the perforator which is going into the flap. So once we have seen the perforator, we complete our incision. The cutaneous incision is completed all throughout the length and width of the flap. And then we start harvesting the flap in a subfacial manner. So what is different in this flap is we don't harvest or include the posterior introsus artery. The posterior introsus artery is typically very difficult flap to harvest. Here you can see that we are incising the fascia. So in a subfacial plane, we are harvesting the flap. We are not going into any septum. So that is the septum wherein the posterior introsus artery is there, but we don't want to go in that septum. That is the perforator of the posterior introsus artery, the very large perforator which we are seeing. But again, we don't want to dissect that, so we have sacrificed that. So fairly rapid flap harvest. Here at the base, you can see a perforator which is entering the flap, which is visualized. We safeguard that perforator. We don't want to traumatize it. We sprinkle some lignocaine on it. And then, yes, we just rotate the flap into the defect. And here you can see that it is a bleeding very well, a very well settled flap at around 3 weeks of follow-up. So here the anterior introsus artery perforator flap, as I showed in one of the images, other spectrum of this flap is we can comfortably cover the volar aspect of the defect, even the palmar aspect of the defect. Only thing is we have to, the proximal palm can be comfortably covered. We can cover amputation stumps as well. So this is a very versatile flap. We can use it in a suprafacial as well as a subfacial manner. Again, on the undersurface, you can see that the posterior introsus artery is not involved. It is based on the plexuses. It is propelled and it can be used to cover the defect. This is just showing one of the complications. There is distal necrosis, but eventually the flap settled well. So my point to stress over here is instead of going for the conventional posterior introsus artery flap, go deep, dissect deep with the likelihood of damaging the posterior introsus nerve. This is a very safe flap. We just have to keep the plexus on the dorsum of the hand near the wrist joint intact. There is also no need to identify the perforator, which I shown. But I've just demonstrated it. I've shown it for the purpose of demonstration. Otherwise, there is no particular need to identify the perforator. So that is how anterior introsus artery perforator flap can be performed. I'll share another video of a local flap for a thumb defect. Do we have time? Okay, I'll close this.
Yeah, one more flap.
Stop sharing and start sharing again. Is my screen visible?
No, sir. Yes, visible, sir.
So yes, we have here the dorsoradial flap for management of thumb defect. Very easy flap, can be comfortably done. Also can be done under local anesthesia. So here we have a thumb defect. The radial border of the flap is ulnar to the superficial branch of radial nerve, and ulnar border of the flap is radial to the radial border of FCR. So we mark the axis of the radial artery over the thinner eminence with a handheld Doppler. Classically, we start harvesting the flap from proximal to distal. We initially gave a small incision so that the vascular structures can be harvested and included in the flap since the very beginning of the flap. So here you can see that subdermal flaps are being raised. Fascia is not breached yet. Similarly, subdermal flaps are raised on the other side, and we identify the vascular pedicle. So it is very easy to identify. It is just lying below that. If you tease a bit, we can easily identify it. Once the vascular structures are identified, then we go ahead by incising the entire flap. Subdermal flaps are raised on the lateral sides because they help us in the donor side closure. Once the flap is rotated into the defect. So we are now identifying and ligating the radial thinner artery. So the radial thinner artery is ligated, cut, transected, and included in the flap. So after that, the flap harvest is fairly rapid. We can use a scissors, we can use a knife or cautery as well. So we have to go from distal to proximal, or rather from the proximal thumb to the distal thumb, taking care that we include the vascular pedicle in the flap. We just have to keep ourselves below the vascular pedicle. Fascia is incised. The pivot point, as we discussed, is around 0.5 centimeters proximal to the IP joint, because that is where the vascular communications are, and that is the basis of this flap. So we don't have to go too close to the IP joint. We have to at least keep a distance of 0.5 centimeters. And then as we reach the pivot point, we incise the area between the defect and the flap so that this tail can be used to bridge that gap. So this is how the tail bridges the gap between the defect and the flap. And you can see the nicely bleeding flap and a well-settled flap over thumb defect. So this is the radial thinner flap for managing a thumb defect. So I think that was the spectrum. Do I share something else, or we are done? The audience must be bored.
So basically, in this we will discuss.
I think you are muted. I am not able to hear.
Are you able to hear me now?
Yes, yes.
I'm sharing few cases, so we can discuss the things.
I'm sorry, Amit, I was not able to hear. I was on volume was low.
Okay. Can you stop sharing, sir?
Yes.
So,
Yes.
Because this webinar is for discussion, so I'm
Yes.
sharing few case. So
Yes.
we can discuss the inferences.
Right.
Probably you are able to see my screen.
Yes. Yes.
So first and foremost point I want to highlight, because don't do these type of dressings in fingertip injuries. This is message for the audience, because sometimes we encounter that the dressing is rounded all over the fingertip. So with the bleeding, when it dries up, it is caked like anything, and if some part is having some vascularity, it may be hampered. So the idea is to do vertical longitudinal dressing, and you can join the adjacent finger as a garter. Sir, you have some idea, Dr. Nikhil?
No, absolutely yes, absolutely yes. Because what happens is when we do a flap, particularly a homodigital flap like a VY advancement flap, and we do this type of dressing, and there is no absolute hemostasis on table, the dressing gets soaked, we discharge the patient, and after some time it dries up. And when it dries up, as you said, there is a constricting effect, and the vascular pedicle is likely to be compromised. If we have to do circumferential defect, we have to see that the patient is with us and we observe him every few hours, so that if we find that the dressing is soaked, it can be changed. If not, we should always avoid circumferential dressings, and we can use adjacent finger, and we can dress it in a different manner. Just avoid circumferential dressings. So that is a point which is very important and which should be considered.
And second thing, see, you can see the ring in the adjacent finger. So whenever some injury is there, so all the bangles, rings should be removed from that part.
That is especially true for burn injuries as well, because in trauma, if we are doing a pedicle flap, again it leads to dependent edema and removal becomes difficult. Anyways, it should be removed, but specifically if it is a burn injury, it should be removed at all costs, because otherwise it might lead to ischemia of the finger.
So when I removed this dressing, patient was having this oblique amputation of middle finger, and the only base of the nail was intact. You can see.
Yes.
So Aviral, can you comment?
Sir, comment in the sense, like, what do you want me to?
Can you describe the defect, or what are your thoughts to manage this?
Okay, so it seems to be more of a transverse sort of a amputation of the middle finger at the level of the distal phalanx, and it seems like there is some bone also exposed in the center of the wound. So I think the defect needs some coverage because it has exposed bone, And in my opinion, I always think if I can go for conservative management in all these defects. But since the bone is defect, I'd like to cover it with the flap.
Dr. Thawar Chand, do you have some idea or you have some opinion? Madhusudan?
Hello, yes, sir.
Yeah, Madhusudan, you want to add something?
Is there any nail bed available, sir, there?
Yeah, base of nail bed is available.
Maybe 2-3 mm only, huh, sir?
Yes.
Then I think we should remove it and flap cover after that. Debridement, removal of the, if it is very less small piece, then remove it and followed by a flap cover for it.
Yes. Anyone want to add in this? Panse, sir?
Yes, I think the flap is required is pretty much clear for this particular defect. So we have got 3 conventional time-tested options for this. I think many would go for a cross-finger flap. Thinner flap, it is already in position. So thinner flap also looks like a very good option. My personal choice in this case would be a Venkat Swami Volar VY neurovascular islanded advancement flap. So same finger, it can, the defect dimensions might be around 1.5 centimeters, but it is distal to the DIP. So I think that would be a good option for this particular defect.
Okay. What about nail bed?
Too small, I think it will definitely lead to a hook nail. Better to have it removed and then think of other option. Hardly any nail is there. Nail bed is there.
Any role of dermodesis to expose the part of the nail?
You mean to say aponychial flaps and
Yes, sir.
but I don't have much experience in managing these type of defects in with respect to giving nails. But I think it wouldn't be of much benefit when the residual remnant is so small. It almost always leads to problems at a later date, especially hook nails.
Yeah.
We then again need to go in and then remove at a later date because it gives a painful scar, it pinches on the flap, and so on and so forth.
Okay. So I did the same. The Ventaswamy flap for the defect, but I did not remove the nail bed, and
Okay.
I did dermodesis to expose the nail.
So do you have long-term outcomes of how this look?
Yes. So this is the immediate pictures covering the tip of the, and you can see the dorsal exposed part of the nail. And this is the X-ray pictures. We took it at follow-ups. Fingertip, it looks like this.
Right. Excellent outcomes.
Yeah, but as you told that there may be some nail problems. So nail was there, but but sometimes I prefer, and I tell my patients also that you keep on cutting the distal part of the nail.
Yes.
If some nail is there, no, it is bad. It is good cosmetic than no nail.
Right. And we can always remove it at a later date as well. I do agree to what you say, because hook nail is sort of a sequel when we don't have adequate nail bed. But if we inform the patient beforehand that you are going to have a hook nail, if you are okay with it, fine. If not, we can always go in and remove at a later date. Very small procedure to be done under local anesthesia.
Yes.
So if patient is accepting, definitely we should go ahead and give whatever nail we can.
Yes. Then this is the range of movement at DIP joint. we were able to achieve. Sir, you want to add something? Vinay Goyal, sir, you want to add something?
No, actually, I was thinking about the nail bed only. So I like this idea that we should not remove it primarily, and we should inform the patient, because even if a small nail is there, that is cosmetically good. Yeah.
So quickly, I say one more case. Case. So this 23 years old male, he had chain entrapment injury in his motorcycle, and his right thumb is amputated at the base of distal phalanx level, and distal part is crushed, as you can see. Volar skin is not good, and it is just at the base of nail. So, Panse sir,
is it a Allen type 3 or a 4?
4.
If,
Yeah, 4.
okay. Again, we have got multiple options. We have one thing we didn't discuss is the Moberg's advancement flap for managing of thumb defects. So I think Moberg's flap is also a good option. The only thing is it leads to flexion at the IP joint. So that is why I'm not very comfortable using it. For this, I think I would prefer a radial thinner flap. The video which we saw, almost a similar defect. Single stage, donor side can be closed primarily. No chances of first wave contracture. The FDMA can also be used. I think multiple flap options over here. It zeroes down to the comfort and comfort of the surgeon basically. And so yes, radial thinner flap would be my flap of choice over here. If there is adequate soft tissue over here, we can probably even get away with a graft. Sometimes skin graft works well for these defects, especially when it comes to sensory recovery. So sensory recovery of grafts are much better than those of thumbs of flaps.
Any thoughts for, because it is an important thing you pointed out, when to do skin grafting for the fingertips? So
yeah, when skin graft, I think our threshold of doing skin graft should be very low. If at all bone is not exposed, and if by nibbling of the bone we are not sacrificing significant amount of length, a skin graft gives much better outcomes, especially when it comes to sensory recovery. So I think first choice should always be skin graft whenever possible. When no critical structures are involved, go for a skin graft. If it is involved, then only we should consider a flap. And again, it also depends upon a lot of, I think, social parameters come into play when we are deciding managing a finger tip defect. So those factors also must be considered.
Do you consider the second layer palmar graft? Or
yes, we do. We do second layer palmar grafts and second layer plantar grafts. We do for burn contractures as well, and for traumatic defects also we have been doing it. The aesthetic outcomes are excellent. Palmar skin is replaced by palmar skin or plantar skin. Sensory recovery is excellent. So I think if it is a small defect, you should always go ahead with a second layer palmar graft or a plantar graft.
Yes, second layer palmar graft I also prefer. So, Aviral, do you have some idea, another idea of using this distal part?
No, sir, I actually don't prefer to use it because I'm very fearful of the infection that the bone may catch. Sometimes in these injuries, when the distal part is very much crushed, then we can see that we have a well settled flap at 2-3 months, but at 6 months, 4 months, 5 months interval, the patient may come with some abscess. So I prefer not using it most of the times.
Initially, that time, because in the LN2 and some 3 also, this graft reposition flap technique works well. So I tried in this case also, because patient was also willing for having the length of the thumb. So this was the X-ray, and we have discussed this thing. So I used this bone graft, and then nail bed graft was done, and the defect was covered with the cross finger flap. Do you want to comment on this issue, or shall I carry forward?
Please continue.
Okay. So then I divided the cross finger flap, and but one problem encountered, that that nail was not surviving well. So when I divided cross finger flap to cover that area, I did the local rotation flap from the dorsal aspect of the thumb.
Okay.
There was some delayed healing of the radial side of the wound. If here I want to point out, if suppose some part of the nail bed is there, then these techniques work well, because but in this case, whole nail was avulsed and dorsal skin was also not good.
Right.
But you can see after a year, he had good outcomes. Although
I think
nail
this
was
technique is an excellent technique, especially when you see it in long term. We don't want to believe it that it works, but we have seen the results of Vijay as well, and we always feel that this is not going to work, and this long segment of bone provided only with a vascularized cover on one side, other side there is no vascularized cover. It leads to complications in the early post-op period. But these are excellent outcomes at 1 year follow-up. I mean to say, it's difficult to give these outcomes with any other flap. It is almost looking like a thumb, and if he puts in an artificial nail, it is almost the entire length is preserved, and aesthetic and functional outcomes are excellent.
And second thing I want to highlight here, because I learned from this case, because he was kept for a long time in the dressing. Once all the things settled, then I felt that his cross finger is also got lighter than the normal dorsal skin. After that, I tried in many patients. Then I used to cover with the intensely used to cover with some dressing. So it became lighter in color.
Yeah. These are excellent outcomes.
Thank you. And this is the range of movement of the same patient. So anyone wants to comment on this or something, someone want to add on this? Okay, if not, then we will hand over to Rosa official, Dr. Vinay Goyal sir, President of Rosa, to sum up because our time is 9:30.
Thank you, Amit. So this was a fantastic experience and a very comprehensive, elaborate discussion over all the flaps. And at least to me, there were many new things. And Amit, you are keeping this monthly promise. You are fulfilling monthly promise very well. And perhaps this is the last webinar in my presidency. So thank you very much, Dr. Pense and all faculty. And thank you. Good night.
Thank you, sir. Thank you, Amit.
Thank you.
हो गया